A very good evening to all of you. At the very beginning, we express our sincere thanks and gratitude to Dr. Jyotidev and his entire team for giving us an opportunity to chair this session, and also congratulate them for the meticulous conduction of this JPEF yearly. Today's topic is Pioglitazone, multifaceted role in diabetes continuum. All of us, we know that Pioglitazone is a thyroid derivative. It lowers blood sugar. In addition to this action, it has got additional effects, like in dyslipidemia, it increases HDL cholesterol and decreases triglyceride, but no effect on total cholesterol and LDL cholesterol. Also, it is very useful in metabolic associated steatosis liver disease, previously known as metabolic non-alcoholic hepatorenal disease. Now, to deliver this session, we have a excellent senior diabetologist, Selvapaandian sir from Chennai. Introduce.
So, I invite Dr. P. Selvapaandian to talk on this subject. He is a director of Kamachi Diabetic Center and Research Center, and he is a consultant diabetologist in Selvapaandian Diabetes Care Center and Bharati Raja Specialty Hospital, and he is a teaching faculty in Annamalai University, Chidambaram. And to his credits, he has received a lot of awards based on Best Diabetologist Award, Maruthova Tilagam Award, and Maruthova Kalaratna Award, and Best Doctor Award from various meetings. So, over to you, sir.
Good evening, all. Thank you, Chair, for the kind introduction. And once again, I'd like to thank Jyotidev for inviting me, and for the USP. It's a sponsored talk. I thank them also, and it's a wonderful opportunity. And you all know Pioglitazone still it is in the controversy, but we should not forget about its efficacy. One of the best insulin sensitizer and one of the best drug for insulin resistant. No other drug is available except this drug. If you are going to use it judicially, this is going to be a wonderful drug. That's what we are going to see today. And its multifaceted role in diabetes continuum. That's what I'm going to talk. Everybody is talking about the global emergency, the diabetic epidemic, and we all know how it is increasing. In IDF 2021, they told it is 50 crore, and now in another 4 years, it is going to cross nearly 80 crores. And one thing, very important thing is, you can see the right side. You can see the impaired glucose tolerance. It is 541 million, more than 54 crores, whereas diabetes is only 53. So both are there. So dysglycemia is more prevalence. If you take the total diabetes and the pre-diabetes, it is very, very high. And 3 in 4 adults with diabetes live in low and middle income countries. That's one important point for this molecule. And diabetes in India, already many have talked that it is increasing. We are next to China, but in population we are already crossed China. And this is very important. We all know site of action of pharmacological therapies for the treatment of type 2 diabetes. Still it is emerging. Now we are talking about 13, but still there are going to be many targets are going to come. It is emerging and research is going on. We are going to see. And here Pioglitazone, you can say, as I told you, it is a very good insulin sensitizer which reduces the insulin resistance like no other OHAs. And positioning of Pioglitazone, this is a very important slide. You can see portion of patients in whom the benefits are likely to exceed risk. First, the oral agent, insulin resistant patient with renal impairment and cost concern, metformin contraindicated patient, there it will be a very good, wonderful drug. The second, on top of metformin, in insulin resistant patients, and you can see the following markers of insulin resistance predict a good and sustained experience reduction: abdominal obesity, slightly increased liver enzymes, and low HDL cholesterol. Almost most of the Indian phenotypes have these properties, and it will be a very good drug in the drug-naive patients. And at high risk, high severe risk population, you can post-MI, post-stroke, chronic kidney disease, diabetic dyslipidemia, and NAFLD, that has been changed as metabolic syndrome as MASLD, And thirdly, you can see triple oral therapy. When to avoid injections seem preferable when the injections has some problem or patient's inability or difficulty or something in that cases. And along with insulin also, when you do large doses of insulin, because in our population, not only the secretory defect, the insulin resistance is also very high. In that situation, certainly this is going to be a wonderful drug in reducing the dosage of insulin also. And it is a potent insulin sensitive, as I was repeatedly telling you. The core pathophysiological defects in type 2 diabetic are insulin resistance in muscle and liver and beta cell failure. So insulin resistance in liver results in excess glucose production during the sleeping hours, leading to fasting hyperglycemia, which is an important phenomenon which is seen mostly in our Indian phenotype. And insulin resistance in muscle leads to postprandial hyperglycemia, and progressive beta cell failure leads to the insulin resistance in the liver and muscle. And protection of multiple organs is a very important slide. You can see reduction of 47% of secondary stroke in patients with previous stroke. That's what it has been approved by ADA just a couple of years back as a outcome benefit, because many were talking now also my friend was asking about Pioglitazone. I told Pioglitazone has outcome benefits. It is I think secondary prevention is there, like protection of stroke and MI reduction and death in patients with CKD with proactive trial has shown, reduction of microalbumin of quarter trial, and reduction of 28% reinfarction in patients with previous MI proactive, 37% reduction of acute coronary syndrome after previous MI again proactive, and periscope stop of progression of coronary atherosclerosis, reduction in carotid intimal thickness Chicago trial. These are all the trials which have shown how much it prevents the multiple organs protection. And I think Pioglitazone, again the major cardiovascular outcomes, what I shown in the graph, everything is again here, 16% reduction in the proactive trial in the composite risk of all-cause mortality and non-fatal MI and stroke in type 2 diabetic at high risk of macrovascular events, and meta-analysis nearly 12,000 patients with 9 RCTs, cardiovascular events, MACE, composite of non-fatal MI, non-fatal stroke, cardiovascular death are reduced by 23% in pre-diabetic and insulin-resistant subjects and 17% in diabetic patients. And meta-analysis of nearly 10,000 of 10 RCTs showed reduced recurrence of MACE by nearly 26%. And again, this meta-analysis, again 19,000 patients within the 26 randomized control trials, 20% reduction of the risk of MACE. So the benefit of Pioglitazone are consistently greater in secondary than primary prevention. That's the important point from this slide. And connecting link, I think Chair was talking about the NAFLD, and now this has a very good connection with diabetes, and you can see both conditions share underlying pathophysiological mechanism that exacerbate each other. Diabetes exaggerates NAFLD and NAFLD exaggerates insulin resistance. So both are very, very important comorbid conditions. And you can see type 2 diabetes and NASH are both consequences of insulin resistance. That's what insulin resistance contributes to NASH. Insulin resistance induces triglyceride lipolysis in adipocytes and results in excess free fatty acid delivered to the liver. So NASH is largely unrecognized complication of insulin resistance. Still it has been not talked much, but it's emerging as a very big comorbid condition in the diabetes population. And global NAFLD prevalence, you can see again everywhere it is the same thing. The prevalence is very high, and nearly 55.5% is the prevalence of NAFLD among type 2 diabetic, more than 50%. That's an important point to note. And risk stratification. Patients with risk of NAFLD, this FIP score is very important. If it is less than 1.3 and if it is more than 1.3, and if it is less than 1.3, refer back to the primary care. Management of cardiovascular risk factors through the lifestyle intervention and appropriate medication should be used. And if it is going to be more than 1.3, again you have to do vibration control transient electrography, which is a very common thing now. It has been done in everywhere. And liver stiffness measurement, enhanced liver fibrosis, and all these things have to be measured. According to these things, you have to grade, and certainly in the extremely high risk patients, it has to be referred to the hepatologist or the gastroenterologist who will be managing this very efficiently. And again, the drug which can be used here is only 2 drugs have been used here. One is the Pioglitazone and GLP-1 receptor antagonist, and this reduces the liver fat. Strongly consider that reduces the NASH is again these both molecules, and which reduces NASH is Pioglitazone and GLP-1 receptor agonist. Other drugs don't have much of benefits except these 2. And role of Pioglitazone in NAFLD, it reduces the insulin resistance, reduces fibrosis, very important factor which is not able to do with any other drug, and decreases the lipid concentration and reduces the inflammation. So the vast majority of meta-analyses have proven that pioglitazone is both safe and effective in treating patients with NASH, even in those with significant fibrosis. That is the only one important factor, fibrosis, which can't be treated by any other drug, none other than pioglitazone. And long-term pioglitazone treatment is effective and safe for patients with NASH and pre-diabetes or type 2 diabetes. This is nearly with 101 patients with pre-diabetes or type 2 diabetes with biopsy-proven NASH who have been recruited, and all patients are prescribed with hypocaloric diet and then randomly assigned to pioglitazone 45 milligram or placebo for 18 months. And primary outcome was reduction of at least 2 points in non-alcoholic fatty liver disease activity score in 2 histological categories without worsening of fibrosis. And secondary outcomes, histological outcomes, hepatic triglyceride content measurement by MRA and metabolic parameters. These were the aim. And you can see after 18 months of pioglitazone treatment, on primary and secondary liver histological outcomes, you can see long-term pioglitazone treatment is safe and effective in patients with pre-diabetes in the all stages of liver thing, where steatosis, inflammation, ballooning, fibrosis, everything was statistically significant. This is the important and even the primary outcome was very statistically significant in reduction of all the histological features. And metabolic and hepatic characteristics after 18 months of pioglitazone, again, it was all shown to be you can see the total body fat by DXA, it was statistically significant. And again, your 2-hour plasma glucose level also was very much reduced, and that was also statistically significant. And your liver fat content also reduced very much. Again, that was also statistically very, very significant. And alanine and ALT was also very much reduced, which was statistically significant. Lastly, your HDL cholesterol increase, that was also very statistically significant. So liver fat and insulin sensitivity before and after 18 months of therapy, you can see that triglycerides reduction, hepatic insulin sensitivity is increased, muscle insulin sensitivity also increased, adipose tissue insulin sensitivity also increased. So it is such a wonderful drug in increasing the insulin sensitivity and reducing the insulin resistance. Again, the plasma AST also reduced, plasma ALT, HOMA score improved, and again adipo-IR also improved in this study after 18 months of pioglitazone therapy. And in conclusion, 3 years of pioglitazone treatment also long-term metabolic and histological improvements in patients with pre-diabetes or type 2 diabetes and NASH. Results suggest that NASH progression may be halted and natural history of disease can be modified with the use of pioglitazone in this patient. That was the conclusion of the study. So effect of pioglitazone on NAFLD in type 2 diabetes using NAFLD fibrosis score. It is an Indian study, prospective interventional study conducted over 3 years at D.Y. Patil Hospital, Maharashtra. 150 patients were included. Baseline NAFLD score, complete blood count, liver function were carried out. Again determined after 6-month therapy with pioglitazone. You can see the mean body index and the HbA1c reduction was very, very significant in this study. And again here also you can see 6-month treatment with pioglitazone significantly reduced HbA1c, AST, ALT and NAFLD fibrosis score. Effect of pioglitazone on lipid profile and liver enzyme in type 2 diabetic. It is a single-arm clinical trial of nearly 110 poorly controlled type 2 diabetic patients, mean age of 54 years, who are on maximal dose of metformin and glibenclamide were enrolled. So again, this is one scenario where you can identify patients on already sulfonylurea and metformin and uncontrolled diabetes. Again, this will be a wonderful drug. That's what the study has shown. Patient received an add-on pioglitazone for 3 months, and you can see the results before intervention and after intervention. Your HbA1c, triglycerides and liver enzymes and weight also was almost not significantly reduced. So add-on pioglitazone is a good anti-diabetic agent in patients with type 2 diabetes who do not respond properly to maximum dose of glibenclamide and metformin. It improves your liver function also. And on lipid profile and liver enzymes in type 2 diabetic patients, again I showed you the same effect. It improved the liver enzymes, HbA1c level, triglyceride reduction. Weight was not that much increased. Again, this is a placebo-controlled trial of pioglitazone subject with non-alcoholic steatohepatitis, 55 patients with IGT or type 2 diabetes with liver biopsy confirmed NASH. Treatment, 6 months of treatment, evaluated for hepatic histologic features and hepatic fat content by magnetic resonance spectroscopy. And you can see all the liver enzymes reduce, inflammation, plasma AST, hepatic fat content by MRA, and plasma adiponectin increased, steatosis and fibrosis before and after treatment. You can see the changes. It was significant. So pioglitazone led metabolic and histological improvement in NASH. Diet plus pioglitazone improved glucose control and glucose tolerance. and normalized liver enzymes, decreased ALT by 58%, hepatic fat content by 54%, and these all were statistically significant, increased hepatic insulin sensitivity by 48%, improved histological finding like steatosis, ballooning necrosis, inflammation, and greater reduction in necroinflammation, 85%, and adverse reaction was seen only one subject, fatigue and mild lower extremity edema was seen with only one patient in that study. And again, one more systemic review with network meta-analysis, comparative efficacy of pharmacology therapy for fibrosis improvement and resolution of NASH. Here also it is a meta-analysis of nearly 26 trials with 5,000 and odd patients and 23 interventions, follow-up duration 24 to 104 weeks, primary outcome more than one stage improvement in fibrosis, secondary outcome NASH resolution. The results, odds of achieving at least one stage improvement of fibrosis was better with your pioglitazone than with the obeticholic acid or vitamin E, and secondary outcome like NASH resolution, semaglutide, liraglutide, and vitamin E and pioglitazone all showed a better resolution, and pioglitazone lastly lanifibranor, which we don't have, and all this showed a superior results. Probability of NASH resolution at least one stage fibrosis was seen with the vitamin E and pioglitazone, and with pioglitazone also the same thing was been seen. And here the sucrose score also showed various drugs which all showed better resolution of NASH, semaglutide, liraglutide, vitamin E, pioglitazone alone, and Amcol, lanifibranor all showed better improvement in the NASH resolution. So now the ADA standards of care in diabetes recommendation. Pioglitazone or GLP-1 receptor are the preferred agents for the treatment of hyperglycemia in adults with type 2 diabetes with biopsy proven in NASH or those at high risk for clinically significant liver fibrosis using non-invasive tests. Early diagnosis and treatment of NAFLD offers the best opportunity for cirrhosis prevention. Pioglitazone and GLP-1 receptor agonist has shown to be effective to treat steatohepatitis and may slow fibrosis progression and decrease cardiovascular disease, which is the number one cause of death in people with type 2 diabetes and NAFLD. And again, 2024 ADA, statements from ADA standards of care, pioglitazone improves glucose and lipid metabolism and reverses steatohepatitis in people with pre-diabetes or type 2 diabetes and even without diabetes. Fibrosis is also improved in some trials, and a meta-analysis concluded that pioglitazone treatment results in resolution of NASH and may improve fibrosis. Pioglitazone may halt the accelerated pace of fibrosis progression observed in people with type 2 diabetes and is overall cost effective for the treatment of NASH. So, take-home messages, we know the global diabetes crisis increasing and the cost of therapy, pioglitazone role in insulin sensitivity, no other drug can do wonderful job than pioglitazone in the increasing the insulin sensitivity, cardiovascular benefits, secondary benefits, I showed you even stroke, MI, everywhere, the cardiovascular benefits, and efficacy in NAFLD and NASD is very, I think many trials have shown, and we have enough evidence for that. And guideline recommendation, leading diabetes and liver disease guidelines including ADA 2024 standards recommend pioglitazone or GLP agonist for managing hyperglycemia in patients with type 2 diabetes and NASH or significant liver fibrosis, underlining its importance in comprehensive diabetes care. Thank you.
Saroglitazone using in the NAFLD, so what is your take on this? Saroglitazone.
Yeah, saroglitazone. But saroglitazone, yeah, certainly is used in the thing NASH and all. But outcome benefits still we need more trials. But here we have seen the outcome benefits are there with pioglitazone and GLP-1. But saroglitazone again a wonderful drug in reducing your triglycerides, and NASH also it has been approved. But outcome benefits still we need more studies.
Thank you, sir.
Sir, hello. Sir, did you get any side effects of pioglitazone, like bladder cancer, acute macular edema?
In my, I think it started in 1999. At that time, only alpha glucose inhibitors was new drug. Even DPP-4 was not there. So we used left and right. Rosiglitazone also wonderful drug. But till now, I have not seen any cancer cases.
Any fracture in
that is there. That is
postmenopausal lady.
Yeah, that is there in elderly postmenopausal women. You should be careful. That is there. It's better to do some dexasan or something to know the bone health or something. That you should be cautious. Because first in these patients, because many of the patients who I'm using pioglitazone, weight gain is not at all a problem. Weight gain is not there. Much of weight gain is not there. If the weight gain is there, your monitoring needs to be more. You have to monitor those patients, and if it is going to be more, if it has any other reason, you have to rule out those reasons. If it is purely because of pioglitazone, then you have to be careful, use a low dosage, or you can decide according to the comorbidities.
Okay.
So the newer variant lobiglitazone, is there any data available about the superiority of that?
Lobiglitazone, they claim that there is no bladder cancer. But outcome benefit, we don't have anything. Like your pioglitazone, I showed you so many organ protection. Like that thing, we need some studies. The outcome benefit has to be shown in the trials. Then we can prescribe. And only one point is there, it is equal efficacy, and bladder cancer is not there. That's all. But here also bladder cancer is not there, and there are some precautionary things are there in patients who are having hematuria or any cystitis and other things, family history of any cancer. Be careful in that patient. That's all. So.
And classically, we were told that you have to stop pioglitazone when you are initiating insulin. But in one of the slides, you told that when you are failing with insulin, also you can add pioglitazone.
Yes.
Yeah. Is that okay?
High dose of insulin. I told you, where you require, we'll be pumping in on insulin in some patients. They'll be requiring high doses, 100 units, 150 units, 200 units and all. In that case, a small dose. I have not used more than 15 milligram. Certainly, it has a change. Because mostly these patients are having insulin resistance, peripheral insulin resistance. That peripheral insulin resistance is very much reduced with the pioglitazone.
Thank you, sir, for the wonderful talk. But I am reminded of the 2007 controversy, glitazone controversy, which is published in New England Journal of Medicine. And from there are so many things they have mentioned there. And then they accepted that pioglitazone is good, but glitazone as a whole will increase the blood volume, will precipitate edema, and can precipitate heart failure. And is not good in patients with hypertension. Although the studies recommend that, but this is a class effect of this medication.
It was
that controversy is still fresh in my mind.
It was banned twice in 2013 and again in 17 or something. But on the two occasions, it was very, very difficult for my patients to manage them even with insulin. That was the thing. So if you select the right patients, there are some patients, that is the precision medicine, where, to rule out which drug suits better for the genetically. Like that, there is some genetic predisposition for this drug. If you select those patients with high insulin resistance, certainly this can be used. High volume, that we are not using in India. Nobody is using, I think so, except some few person. But in that case, hematocrit is going to be a problem. Volume increase is going to be a problem. You should water. Diabetes is nothing but monitoring. Monitoring is diabetes. So without monitoring, if you are going to do, you will be landing up in problems. That is the thing in diabetes. That diabetes is the only endocrine thing where you need more monitoring than other endocrine problems.
Sir, the fibrosis contains only is limited to liver, or we can also lung fibrosis or whatever, renal fibrosis patient. Because I am using one of my post-COVID patients, I am using for lung fibrosis.
We don't have any specific studies. Certainly fibrosis means, I think so, because it is a genetically acting drug. It is a drug which acts very genetically. So I think so, it should have some effect on other things also. But we don't have any evidence or trials.
We have seen some of trials and we have used it for the lung fibrosis patients.
Probably,
Thanks.
Sir, it was an excellent talk.
No.
Good evening. If the patient gives the family history of cancer anywhere in the body, shall we freely take up pioglitazone?
What type of cancer? If it is bladder cancer?
Any cancer anywhere in the body.
No, it is only for bladder cancer because it has some prevention for other cancers also. Pioglitazone has a prevention in other cancers. So we can't say any cancer, only in bladder cancer, family history or genetically, then you can avoid. Not in all cancers. Because it has some prevention effect in other cancers, but we need some study. It was a observational finding that is, it prevents other cancers also. So we can't say like metformin, anti-cancer drug, we need more studies. Like that, we need more studies to say not in all cancers, only in bladder cancer and family history, better to avoid.
Thank you.